here. In terms of our timing today, the meeting will finish at around 11:15. That is to allow our executives to go to the main reception, those of them who are in the hospital, for the 1 minute silence that is taking place on a Thursday. So, colleagues, if you could help me manage that timing to allow our colleagues to go, that would be really helpful. It is a public board meeting, and obviously we're not able to allow public access in total, but we do have with us our lead governor, Gavin Rimmer, and Mike McPherson from our Council of Governors. So welcome both colleagues to this particular meeting. Hope you find it interesting and useful. This particular meeting is being recorded and then will be put on the internet for anybody who would like to see what it is that went on this morning. And obviously anyone who would like to sit through it again would be welcome to do so, I'm sure, in those circumstances. We have one apology for our meeting today, and that's Simon Shepherd. Do we have any other apologies, Anna, please?
No apologies. No apologies received.
Okay, so we might expect Pravin when he arrives. And,
Martin, sorry, it's Callum. I've just spoken to Pravin. He's clinically. He said he did send his apologies. But...
Okay, so we'll record his apologies then on that basis. Before we start the meeting formally, can I just place on record our appreciation to you as our executive leaders and our divisional leaders, and indeed all our colleagues, for the work that you've been doing and you continue to do in dealing with this virus at the present time. So you're very much valued, very much appreciated, and thank you very much indeed for all your efforts. Excellent. So we'll now start on the agenda proper. As long as I haven't missed anything, Anna, is there anything else that I needed to include? I don't think so. Having read the board papers, has anybody identified any declaration of interest or any conflict of interest? As normal, if you actually do think that in our discussions there is a conflict potentially, then please raise the matter at that time. Thank you. We're now going to the minutes of our meeting held on the 7th of April. That's on page 3 in the pack. First of all, are they a correct record of the proceedings that we transacted last time? All agreed? Anybody not? On that basis, those are approved. Are there any matters arising from the minutes that aren't covered elsewhere on the action log or the agenda? Right, can't see anybody's hand up there, so thank you. So we'll now go on to the action log, which is on page .
The next item, number 3, the DOF was requested to take forward suggested format revision of the report, one of which we have actually got on our agenda today. That as it is in progress, and that has been moved over, so we'll pick that up hopefully for the next quarterly report. The 5-year plan, this item was with regard to having the graphic version all set up and established. Obviously that's had to be put back for the moment and will be picked up as soon as possible. The next item is actually the Cqc Insight reports that will be provided out to the board committees as appropriate. The next item remains open, number 12, because we still have a month to actually identify that patient's safety specialist. The next item, the circulation of the annual report and accounts guidance, I'll send that out to the NEDs just prior to the audit committee on the 20th of May, so that it is all picked up together. NHS Premises Assurance Model, the PAM framework, this will be completed and it has been added to the QAC agenda and work plan for a couple of months' time. The next item, the Social Value Rotherham Charter, that will be picked up, and the Rotherham Together Partnership will be informed at the next meeting. I haven't got the date for that, so I'll enter that up as soon as I've got that. And the next.
Excuse me, Anna, for a moment. Anna, just for a moment. Richard, would you like to comment on that?
Just on that point, I've given that there won't be a face-to-face meeting because of the COVID, I've dropped them a note to confirm that we've supported the charter at last month's board. So I recommend that's closed now.
Okay, noted.
Thank you. All agreed on that? Thank you.
The next item is care hours per day to be discussed with the DOF in order to triangulate finances, activity and quality of care. That remains open at the moment. I don't know if Angela wants to.
I've spoken to Michael last week around the work we're doing around identifying what the shifts are and how we're calculating what use of bank agency, etc. we're using. I identified within the paper, the quality report, the reason for the increased care hours per patient day is due to the reduction in beds and the utilisation of staff across the trust. I'll be providing more information to the exec team on Thursday.
Thank you, Angela.
Okay.
Is that it, Anna?
Yeah, and just the final item is the draft People Committee Terms of Reference, which is on the agenda today. So recommend to close.
Thank you very much for that. All agree with those recommended to close then, please? All agreed? Thank you. The next item on our agenda is the report of the chairman on page 16. So if you could refer to that. And are there any questions or comments anyone would like to raise on that particular report? Okay. I'd just like to reference the Council of Governors meeting that is on this particular report, and just recognise that unfortunately we weren't able to hold that meeting, but as the report says, we did produce the papers, circulate them to the Council of Governors, and ask for any questions or comments on the papers themselves. There is a letter attached to this particular report, which I sent to all the governors in response to 4 questions that were raised by Gavin Rimmer and Hilda Littlewood. So that really, I'd just like that referencing in the minutes if we possibly could. On that basis, let's now move on to the Chief Executive's report, which you have there in front of you. And again, has anybody got any comments or questions to Richard on that report? Lynn, please. Heather, would you like to go?
Right, sorry, I'm ready now.
Sorry, she's on now. Okay.
Okay. So some of them are rhetorical, I think, Richard, but might be worth airing publicly. The antiviral drug that came to light this week in the US, I think remdesivir, if you've had any noise in the system about whether that's likely to be adopted in the short term in this country. How the plasma donations for COVID patients are going to be, how is it going to be organised really, and what category of patient are likely to receive that plasma. And I think there's a strong feeling there won't be a second wave, but that's assuming that the track and tracing and all of that stuff will work. As we go into recovery, how confident are you that should there be a second wave, which some of the experts say would be have an even bigger peak than the first wave, how we could gear up again?
Okay, I'll start off with that, but I'll perhaps ask Callum to pick up the plasma bit of it, certainly. So remdesivir got a bit of publicity, as I think you're referring to, from America, from the early reports unpublished from a study that was done, which showed a reduction in the time to recovery, and a non-significant mortality reduction from 11% to 8%. I guess, as Dr. Fauci in America said, that's encouraging because it's proof of principle that the virus is amenable to antiviral therapies. But certainly we don't know the details of that study. We haven't seen it. And I think we'd have to see that published and then wait for national guidance. Also, because I don't personally know how available that drug is in terms of quantities of it and the production of it. But given that we've got a worldwide pandemic, I'd imagine that they won't be able to keep up with need for some time if that gets widespread usage. Similarly, the evidence for hydroxychloroquine and so on seems to be diminishing, and the prevalence of side effects of that drug seems to be higher, certainly cardiac toxicity, than was initially reported by the president. So I think at the moment, I think we're still some way off having a drug that's going to be widely available and effective. I'll skip plasma donation for a second and ask Callum to pick that up in a second. And your point about what's going to happen next. Appended to my letter is Simon Stevens' phase 2 letter, which we just got at the end, that just arrived in time for the board pack to go out. So the executive are going to be doing a sort of gap analysis against that and making sure we've got everything in place. I think everything depends on what's now being termed the 3T process: test, track and trace, which is the widespread availability of testing, tracking patients and contact tracing, which I think is now dominating the news, certainly with the app and Isle of Wight and so on today. I think there's a very high chance that we will not have a significant second peak. I think we're likely to have a diminishing level of activity between now and the summer. At some point, we may get to a time where we, as across the South Yorkshire system, choose to consolidate our COVID care into fewer hospitals, potentially into one eventually, once the numbers permit that. And that would certainly facilitate the other hospitals from catching up with the non-COVID work that we need to get on with. So there's a lot of uncertainty behind that. But my personal view, I think it's quite unlikely we're going to get a major second peak, because I think if we started to see an uprise, there would be a resurgence of lockdown measures that would likely control that. But I mean, that's the major worry. Perhaps I could just pass to Callum to pick up the plasma section. I hope you're okay with that, Callum.
Yeah, no, absolutely. I mean, I think along with any treatment, I mean, we as a trust were engaged in a number of the national trials to do with COVID treatment. The convalescent plasma will be one of them. And I was talking to Professor Hormus yesterday, who's going to be the principal investigator on that, as he is for the other COVID trials. Similarly, the drug we're talking about from America, I think anything that comes out that will be added as a treatment arm to some of the already existing trials. But it is coming, the plasma treatment, and there's a whole campaign gone out nationally for donors of patients that have had COVID to donate their plasma, and that is going to become part of a treatment trial arm from an existing trial that already exists.
Thank you. Heather, please.
So it's picking up on the comment that Richard made there about we've just had the letter about the moving into phase 2 of recovery and getting activities back to normal. And I appreciate it's early days and the executive are working on it. There are 2 areas that I just wonder if Richard might give us some early insight into. The first one is obviously we've had a significant number of our frontline staff under a lot of pressure, and how will we keep going with dealing with COVID and recover and protect those staff who may need some additional time off. And secondly, in the first phase, we were across the country told to carry on with cancer treatment wherever possible. And looking at our information, and certainly through FPC, whilst we have done cancer work, there's been significant fall off in the amount of cancer work that we've done, and the list building. So what are our plans on the cancer recovery?
Heather, do you think you could have a look at turning your volume up for any further comments you were going to make? Thank you.
Right.
Richard.
Yeah, thank you. So in the first one about, I think, just check I've got the question right. I think it was to do with how do we sort of support our staff and protect our staff when we're doing COVID and post-COVID work. I think what we're going to see is a progressive reduction in the COVID activity. And in fact, we're already seeing that. Our critical care, I think numbers today are 4, whereas a week or so ago they're about 10 to 12. So there's definitely an improvement there. But how do we protect our staff against that? So a couple of things there. One is a critical constraint at the moment for us resuming much in the way of surgical work is the availability of sterile surgical gowns, which is a regional and national issue. And I think it was one of the items that wasn't in the sort of pandemic flu and Brexit stockpile. And I think also earlier in the pandemic response, when general gowns were hard to come by, I think sterile surgical gowns got used as general gowns. So therefore, that's a constraint. And at the moment, the view of each of the South Yorkshire hospitals, independently and collectively, is that we need to preserve sterile surgical gowns for emergency and urgent surgery. And if we were to start elective surgery at the moment, that would be a risk. So that's probably the key constraint. I think the key point is that we will be doing more testing, both the patients and likely, I suspect, of staff in the near future. And I think we could easily envisage that once the prevalence of COVID reduces, all public health measures that are going on, it will become easier to adapt our services to deal with the non-COVID work. I think my earlier comment to Lynn's question about the fact we will probably at some point over the next few months start to move towards having COVID-free hospitals will then, I think, facilitate some of that. What we don't yet know is what degree of routine PPE use you'd need in a COVID-free hospital, because you can only be, depends how certain you can be that COVID isn't present. In terms of the cancer treatment, we've seen a huge fall off, as have other places, in the referrals for cancer. The urgent 2-week waits have fallen off enormously. Now, about 90% of 2-week wait referrals are not cancer in any case, but of course, circa 10% of them are. And we've also had a prioritisation programme in place that Jeff and others have led on that allows us to appropriately allow the timescale response to different patients for cancer referrals to be prioritised. I think I would say probably for me, and I think for most of the executive team, getting that cancer work back up and running as close to normal levels is probably the top priority once we can get out of our current situation. So I think the next phase of this work, which Simon Stevens' letter picks up, is really about how we do that over the next 6 weeks or so.
Thank you, Richard. Jeff, please.
I think it's reasonable to say that actually we have continued to do cancer operating and some urgent cancer diagnostics, both here and using the private sector down the road at Kinvara. And that actually, certainly in my own specialty of colorectal, there has been a reasonable proportion of the patients who have declined to come in, having been offered operation dates. And for colorectal cancer, that's not actually quite so much of a drama, because there's quite a leeway in time as to how soon you need to get their operation done. But I think it is worth documenting that we have been treating all the urgent cancers, those who have run into complications, and those who have needed to be done have been offered dates, and the ones who've accepted have been done. Max-fax cancers, colorectal, breast cancer, some urology cancer have all been done over the last 4 weeks.
Thank you for that. Rumit, could you put
just
on mute,
want to raise
please,
a question about how, as the other activities have gone down, how the Trust is mitigating outpatient reviews, and are they beginning to get those numbers down? Because I have no doubt that as recovery starts taking place, the number of referrals will jump, and clearly that space needs to be addressed to be able to try and help with the ongoing recovery phase.
Thank you. Could I ask George if you could respond to that in terms of the outpatient work, please?
Thank you, George.
So what we've done is ensure that all specialties are doing virtual clinics, and more importantly, all specialties are reviewing their waiting lists. So we're doing a check with them on a weekly basis to where they are. We're at about 50% now, and what we've agreed this week is that once they've done that, we'll either contact the GP and the patient, or we will set up a second review for that patient in a number of months' time to make sure that we're not missing anybody or losing everybody. I would say, based on early this week's information, we're at about 50% of our review list has been reviewed, verified, validated as we work through. And what we've also agreed is that all of our referrals into the organisation previously would have gone on to either a waiting list or a review list for the consultants and others to check and come up as what we call a patient waiting for inputs and ASI. We're going to do away with that completely, but every single patient that we've got on the waiting list, so that one, it's really clear that we've got everybody that's on our late waiting list, and two, that we have a plan to deal with that. Our waiting list shrunk massively because of the numbers of referrals. Once we add those ASIs, as we call them, back onto the waiting list, it'll go back up to pre-COVID levels, and then that'll allow us to actually manage the news and the follow-ups in a sensible, planned way.
Thanks very much, George. Mark, please.
Thanks. I didn't realise we had to put the physical hand up. I thought it was the electronic hand we had to put up. I'll have to get used to this. Back to Heather's point, actually, about cancer, because you've got this second phase NHS letter, Richard, in your pack, but it wasn't called the first phase at that stage, but Simon Stevens' letter on the 17th of March did talk about emergency admissions, cancer treatment, and other clinically urgent care should continue unaffected. But clearly it has been affected. I know Jeff has referred to some patients being reluctant about coming in and meeting their appointment schedules. And Richard, you talked a little bit about referrals being down. But I think Heather's point, and also my point, I think, is about those people already in the cancer pathway. Some of the data later in the papers talks about the number of patients past day 38 has quadrupled. The number of patients over 62 days has increased by 50%. So I'm not sure if all of those patients were patients that declined their appointments. And if they were, whether we should have done more to reassure some patients. Obviously, for some patients, it would have been clinically unsafe for them to come into the hospital. But whether we should have done more to encourage patients to come in and meet their existing appointment schedule.
Yeah, Richard?
Thank you. I can see George has got his hand up. I want to say a couple of words and perhaps ask George to pick up the rest of it. I guess there's a few things there, and it goes back to some of my earlier comments that people after day 38 are generally waiting for, they're transferring usually for a surgical treatment or a cancer treatment at Weston Park, and therefore that will have been limited somewhat by the availability of the appropriate sterile surgical gowns and things I mentioned earlier. Not all of those treatments will be time sensitive, although of course they then violate the normal waiting times. So my understanding, perhaps George can pick this point up, that each of those patients' pathways will have been reviewed and the appropriate clinical teams will have advised about whether or not those patients can wait or not. But I'll pass that to George.
Thank you, George.
Yeah, so we are still meeting weekly with our, call it cancer recovery buddy, I think it's cancer maintenance at the moment. There are 700 patients that we have on our cancer list, and every single patient has been categorised. So as of yesterday, we have 64 high-risk patients, i.e. the ones that will need to be seen, treated, diagnosed in the next week to 2 weeks. We have 120 that are medium risk that we are keeping a really close eye on. And then 133 that are low risk, and then the remainder are the ones that we don't think have got cancer, having conversations with them. On top of that, we're doing 2 clinics, or what we're calling welfare clinics. We're doing 2 a week, every single week, with the nurse specialists by specialty, to ring patients that are on the list to answer any questions, to make sure that we're dealing with what they need, and to tell them where they are on the list and what's going on, to reinforce the message about if they're low risk and when we're hoping to get them in. So I think the clinical teams are really on it from a point of view of the cancer. They're fully aware of every single patient, and we're making sure on a weekly basis that nobody slips through the net.
Okay, thank you for that, George. Any further questions or comments on Richard's paper? Anything, Richard, you would want to highlight specifically before we move off?
No, other than the point that there's a lot in Simon's letter, and obviously we're going to go through that systematically and make sure that we've got everything covered off. The phrase I heard yesterday on a call with local authorities was about the need to be adaptive and iterative in our response to COVID, and I think that's quite a nice way of thinking about it, because it's very difficult to predict exactly where we'll be in 6 months, but I suspect we'll end up in these sort of 100-day planning cycles where we're looking at the next bit of it. And I think that's probably what Simon Stevens' letter says. I think we will then get further letters as time goes on with phases 3 onwards. I think nationally they're looking at a very big opportunity to reset the NHS more broadly, both structurally and in other ways, and to try and accelerate parts of the long-term plan. So we don't exit the COVID period to normal business. We exit to the new look NHS that was the intention of the long-term plan. But I guess we'll pick that up as the months go by.
Okay, thank you. In terms of the response, Richard, to this phase 2 letter from Simon Stevens, when do you feel the executive team will have got their head around that and start thinking about some plans going forward?
I've asked for the draft to be with the executive team next week, and then what we'll do is then bring it through to assurance committees and then to board.
Right, thank you very much indeed. Thank you for that report. Let's now move on to the National Integrated Care System and Rotherham Place report, page 38. You have the report in front of you. Any questions or comments on this report, please? I can't see any questions indicated. So, Michael, is there anything that you would like to highlight for the board from your report?
Yes, please, Martin. I think I just want to cover off how positive the relationship has been across Rotherham Place and indeed the ICS, and we're working very closely at the moment. In terms of the national position, Rotherham FT is one of only 15 trusts that has been selected to lead on the national procurement of PPE. So I think that's a real positive for the procurement team here at the Trust. And I will just pause and take any further questions, Martin. Thank you.
Okay, well, it's certainly good to hear that about the procurement team. And I think we mentioned them last time, didn't we, at our board meeting, and the positive impact that they'd had. So that's good to hear. So no further questions with the look of it. Let's now move on to the operational plan quarterly report, page 41. This is your report again, Michael. Any questions or comments from that report, please? Joe Barnes.
Thanks, Martin. Just an overall comment. If we look at this, it's not a glittering success story. And I understand about COVID, but really that's week 50 out of 52. And I just wonder, as we have done for finance in the past, at an appropriate stage, we might not look back and have some analysis of just why we didn't achieve the things that we said we would achieve. Not for just this exactly now, but at some time in the future, as we did with finance.
Okay, thank you for that, Joe. Heather, please.
Hopefully you can hear me a bit better now.
It's not good, I must say, Heather.
Sorry, I'll speak as loudly as I can.
That's better, thank you.
On the operational plan, just the point that we've made at FPC is that we would also request the criteria of how you judge the success is looked at, because we've had a number of instances where the committee has challenged the RAG rating as showing that we're either on track or off track, and the evidence we see doesn't always square with the RAG rating that's achieved, and then very close to the end the RAG rating changes, often in the direction that we've been alluding to. So I think that's worth looking at as well.
Okay, thank you, Heather. Mark?
Yeah, I mean, I share Joe and Heather's points of view there about a need to review, but my specific question is about service line management, because we've been told over many years that getting that in place and getting it working right is fundamental to basically taking the trust forward and being clear, where that we are achieving a break-even situation and where activity is costing a significant amount of resource. I was just wondering from Michael's and Richard's point of view, how important they see service line management and having that in place across the trust as taking the trust forward in normalish times anyway. And how do you think we can make that happen post-COVID?
Thank you. Those are the questions that I've got that people want to indicate. Could we, first of all, take the points being made by Joe and Heather about the review of the performance of the operational plan for this year? Michael, are you going to take that? And then we'll come back to the service line.
Yes, I will do, Martin. No, I think certainly we had discussions at F&P around the movements in the ratings towards the end of the year. So that is something that we need to look at. I think the deliverables need to be very tangible. Specific and measurable. So we need to ensure that going forwards on future objectives, the position has deteriorated with COVID-19, as Joe says, but one or two other areas, particularly around finance and CIP, we've seen some deteriorations. So we can certainly do a review of the previous year and have a look at the main reasons for the slippage. So I think both are sensible suggestions.
Okay, are we all agreed then we should actually review that in the suggestion that's been made? Richard, do you want to comment first?
Yeah, I agree with that, and I think we absolutely should look back at that. It's good practice to reflect on things, whether they go well or badly, and I'm sure there are lessons to learn. I mean, some of these things were ones we've talked about over the last month or two, and certainly on the board workshop on the 12th of February, we talked about some aspects of this in terms of operational performance and quality of services. So I think COVID gives us an opportunity just to pause and to have a think about why we didn't deliver those and how we need to make sure when we do get when we get past COVID that we have a better track record of delivering what we say we'll do. So I'd certainly support that, and we'll get that done over the next month or two. Can I pick up the service line management question once I've got the microphone? I guess service line management is something that people talk about almost as if it's a sort of panacea to NHS finances. And I remain a little bit of a skeptic about it. I think in principle, it makes loads of sense. In practice, I think it can sometimes divert from people taking appropriate focus on management against budgets and looking at sources of expenditure and variable pay. And I think we know at the moment what some of our areas of focus need to be in terms of getting a control of our run rate. And I think there's a real risk that you put an awful lot of effort into service line management and look at all the apportionments and spend an awful lot of time doing it, and it doesn't necessarily translate into achievable action. So we've had it in my other organisation for some time, and the challenge I keep putting back there is show me some specific action we've taken as a result of service line management that we wouldn't have otherwise taken, and we struggle to find those. I led on the implementation of service line management in mid-Yorkshire some years ago, and similarly, it's an awful lot of work, and I'm just slightly sceptical of the return you get for that over and above focusing on more traditional approaches. Now, saying that, I appreciate that that's somewhat at odds with the general direction of travel that we're all being encouraged to go to service line management and PLICs. And I'm not saying we shouldn't go down that path, but I'm just cautioning that won't be sort of sudden insights into drastically turning our finances around. I think those measures need to be somewhat more traditional and basic than that.
Yeah, Heather, please.
I would just like to support what Richard was saying there. I've been a big supporter of the trust moving down the service line management route. But I also agree that it can be a massive distraction, and in order to make it work successfully, you have to have the basic controls over how you actually manage your system, how you authorise expenditure, etc. And we have demonstrated this year that those controls are not in place, and I think fixing those fundamentals first and then looking at how service line management could be introduced with specific objectives of what it's trying to do would be the right way to go. And I don't think this moment in time is the right time to do service line management.
Okay, thank you for that, Heather. So go on, Michael.
Thank you. In terms of my own view, I support Richard's view in that I think we need to fundamentally look at how we manage financial performance, and that will be part of the performance management reviews that we do on a monthly basis with even more of a focus on the finances. And then we're bringing the data forward at the performance meetings. That's our intention, so we can report to F&P on a more timely basis. And I think once we've managed to demonstrate we've rolled out GRIP across the organisation, then we could start to have a look at service line reporting. But in my experience, the focus on the division's positions down to EBITDA rather than from a service line reporting perspective seems to pay dividends. So I think GRIP is the key. Thank you.
Okay. Well, thank you for those pieces of feedback. Roommate?
Yes, Chair. Point 3.4 on page 45, 2A. Can I just have some clarity with regards to this item which has been closed, which is UECC improvement plan? I don't know whether George can answer that or...
Yeah.
Who's picking that up, please? George?
Yeah, certainly. We put together a UECC improvement plan based on managing to 4 hours and the national standards around 12 hours, etc. And then quite quickly, May last year, we were asked by the national team if we would pilot the new potential UECC standards, which are based around median time in the department, time to be initial assessment, etc. So this plan was quickly out of date within 2 months of actually taking it forward. And so we've got a separate plan completely that's around with the national team working on and developing new urgent emergency care standards. So it was seen that our original plan around 4 hours was no longer relevant.
Okay, thank you, George. So just finishing off on that particular item then. So we are going to obviously reflect on 1920's performance, and the executive team will look at any learnings for that in taking those forward into next year. With regard to service line management, obviously we've got some mixture of views about its impact and benefit, but its timing is also important. So therefore, in terms of this year, it's unlikely we're going to progress too far down service line management in terms of as we recover into the second half of the year, but it's still going to be on the agenda at the right time from the sound of it. So thank you very much for that. So let's now move on to the COVID-19 reports, page 56. And again, any questions or comments on George's report? Mark, you indicated, please. Thank you.
I think it's a great report, and none of this is intended as criticism to George or anything like that. But in the table that's attached on page 58 afterwards, it sort of mirrors Simon Stevens' letter from the 17th of March, which was his instruction basically to the NHS. And the one thing that's missed there is those words which I suppose Heather and I referred to earlier about emergency admissions, cancer treatment and other clinically urgent care should continue unaffected. And I guess my concern is there wasn't a line in that to actually say how do we plan to make sure that happens. All the other lines in Simon Stevens' letter appears to be reflected in the table apart from that one line.
I take your point completely. When this was produced, we hadn't received the second phase. There's a whole new table that's been produced. In fact, Jeff and I had a email conversation last night because I sent it out for comment already to the divisions. So the next report will have the new graph and table in it with the new actions and thoughts forward. And just, this one was very much about what we have done in the first 1 to 2 months of this, because I look back at my diary and actually the first COVID meeting was in January. So it feels like it's been going for a long time, and it has been a couple of months.
It has been a couple of months, George, but I think my point was that your table there does reflect the 17th of March letter. It's all the lines in Simon Stevens' letter, the 17th of March. The only bit that isn't reflected in there is that his desire to continue cancer and emergency.
Yeah, and in the new letter and the new table, that will have that in there. But in reality, we have stopped everything we possibly can. And the only thing we're actually doing is urgent cancers and urgent emergencies.
Yeah. I think, George, obviously if the second letter picks that up, that's fine, but let's not make sure that we don't miss that key area of activity as one of our priorities. But Jeff obviously gave us an indication that a lot of work has still continued while COVID's been going on, and we just need to keep a close eye on cancer, I think, as we move forward, to make sure we get back to the kind of levels that we should, just to give us reassurances back to the community, and in particular those people who are obviously facing the challenges that cancer actually provides for them. Any other questions of George on that? I think picking up Mark's first comment is thanks for a good report, really, George, keeping us informed and an overview about where we're at. And we will obviously keep that going as we go forward, and keeping that monitoring, because the public will also want to know how we are performing and how Rotherham has responded to this particular virus, and obviously what happens next. So thank you for that report. The next item is Assurance Committee updates. And this is just a verbal one. If any of our lead executives and committee chairs want to just highlight anything from their assurance committees this cycle. If we could start with quality, please. Anything that colleagues believe needs to be specifically brought to the attention of the board? So looking to Callum and Angela first. No, yourself, Mark? Sorry, Callum.
No, just to say that understandably, the majority of quality committee focus was on COVID and about trying to preserve the quality of care for all patients through difficult times, including those with non-COVID. We had a lot of discussion about the ethical application and things like patient treatment options form and so forth, but nothing particularly to highlight.
Okay, thank you very much. Let's pick up finance and performance then, please. In terms of Michael and George, anything in particular?
I think it's just worth mentioning that financial performance, we went through our normal report and feedback, and it was really clear that COVID, the actions we've taken, the national directives we've been following have completely changed the way we're going to manage waiting lists, RTT, cancer performance, A&E performance, delayed transfers of care, etc. The whole of our landscape has changed.
Great, thank you for that, George. Heather, anything you want to add?
Yes, a couple of things. Just picking up on what George said there, I think one of the things that we discussed at the committee meeting was not only the change landscape, but how we are going to identify the new practices, which are good practices that we want to keep future. And specifically, I think that's something that the board should focus on over the next few months, because there have been some good learnings coming out of the operational process. And I think also, just on the cancer thing, I think it was particularly worthy of note that the progress that George and his team had made on bringing cancer treatments back on track from where we've been earlier on in the year. We were almost there, weren't we, George? And then COVID came along, which has derailed it. So it's worth noting that significant progress had been made in how we were dealing with cancer within the hospital. And turning to the finances, obviously.
Sorry, Heather. Heather, could you move a little closer to the mic
I'll
again,
try.
please? Oh, thank you. That's much better.
On the finances, obviously, we focused on the significant deterioration that took place in the last quarter. I think further work to be done in understanding what went on there. And I think our focus was almost more on looking forward in terms of the lessons learned, particularly around e-rostering and control and authorisation of agency, bank and staff costs. I know the executive are doing a review on that, and we've asked for that detail to come back to the committee to look at next time. Two other areas of focus that, again, looking forward, is assurance, which we don't yet have around the cash flows for the current year and what budget levels we're actually operating to because of the new financial regime. So that's something that Michael is working on, and we'll find a way of getting that assurance. Clearly, we need to know what cost level we're working at, especially in relation to the exit rate, which was significantly different to the plan that we put together. And I think the final comment, again, which Michael is looking at, is around our control over our capital expenditure and the authorisation process. I appreciate that we've changed the rules slightly to go through COVID on the authority level for signing off business cases. But if we look at the capital spend during the year, we had some additional funding came up very close to the end of the year. But nevertheless, operating within our original budget, right up until month 12, we were being given information that our capital spend was on track. And then suddenly, once we get to month 12, not only is it overspent, but there's a carryover of costs into next year. So I think there's a need to have a further review of how we control our capital expenditure.
Okay, thank you for raising those points. I mean, very critical ones. And we'll need to get our head around what our budget is for this current year, even though we haven't had to produce a plan. Actually understanding what our sort of costs and expenditure actually are quarter by quarter is going to be very important. Thank you for that. Let's move to the People Committee, please, and look to you, Steve, Michael, and then Heather. Steve, anything you want to highlight?
I think you probably mean Lynn from the People Committee point of view. Lynn chaired
I'm sorry, Lynn.
No, it's okay. Lynn chaired the inaugural meeting of the People Committee on the 24th of April. As ever, in these days, it's a virtual meeting, but I think it worked really well. Probably highlighted the need for a People Committee in terms of the size of the agenda and the scope of people-related issues that we need to talk about. We obviously, I guess, as with other committees, had a focus around COVID and how we support our people during the COVID response and ongoing situation. We looked at the terms of reference, which is on the agenda later, and tried to broaden the scope of what we want to do is make it not necessarily adding members to the committee, but making sure that we include people who can attend on a regular basis, who can talk about people issues at the front line and give some assurance around divisional responses to people issues. I think the other thing, Michael and Lynn could correct me if I'm wrong, we still need to, I think, and it's probably a board discussion, agree the demarcation of people issues between the various committees, because some of them do straddle a couple of different committees. So when we talk about workforce and bank and agency, clearly there's a read across to the Finance and Performance Committee, and understanding where, not to say that they can't go to both, but just having a clear understanding at board about the different responsibilities. I don't know if, Lynn, there's anything you want.
Yes, as you said, I think we were feeling our way a little bit. I think we could sharpen up a bit more in subsequent meetings, and I'm sure we will. And when we start to see the plans and the milestones, that will help. And I think we need now an increased focus on the recovery stage and how we support our staff as we come out of the pandemic, would be my only comments.
Okay, thank you very much, Lynn. So perhaps executive colleagues could have a look at this demarcation, please, between the two committees and make recommendations. We we have some history of this. So let's have a review for this next cycle, if we possibly could. That'd be all right, Richard? You could do that? Thank you. Right, we decided that we would keep the assurance committees going on a monthly basis, even though we were facing COVID, particularly so that we could have the assurance committees seeking assurance from different perspectives, both from finance and performance, from a quality perspective and a people perspective. So therefore, we'll continue with the assurance committees on that basis, recognising that the agendas have, by necessity, needed to change and reflect the challenges that we're currently facing. So are we all comfortable to move on to the next item on our agenda, which is the monthly performance report? This is obviously the overview report, and then we'll go into the specific reports that are following. Any comments from colleagues initially on the overall monthly integrated report? Are we happy to move into the individual reports and pick items up there? Right, let's now move on to the quality report, please. Page 70 of our agenda. And have we got any comments or questions of Angela and Callum on this report? Anybody got any questions, please? Lynn? Yes, Lynn, thank you.
It may not be a question anybody can answer. It's one for Callum that wouldn't naturally crop up in this cycle, but perhaps to get the information and report through the quality committee, is on organ donation. And I think I might have wrongly assumed that all of that activity would just be suspended during the pandemic. And I dropped an email to Claire Windsor, who's the clinical lead on this, just to say, you get in touch when you're ready to resume the meetings. But I've picked up nationally that there's a push from NHS Blood that some activity should be carried on. So I just would like some clarification on that as Organ Donation Committee Chair.
Thank you. Just a moment, please, Callum. Do we have any other questions or comments from colleagues? Okay, Callum, thank you.
Whilst the organ transplantation nationally is being minimised, there are clearly patients that need emergency transplants or transplants, otherwise they'll die. So they are trying to preserve some. And I think whilst our numbers are generally low, I think it is something that we should entirely preserve, not least given the fact that this is not going to be just a couple of months, this is going to be a long dragged out process. So I think the Organ Donation Committee should fundamentally continue, clearly doing it virtually rather than physically.
Okay. Thank you. So you want to speak again, Lynn?
Yeah, just a supplementary one, and just a quick one, Callum. I've had no response from Claire, so as medical director, could you have a quick conversation for quality committee so that I'm and get it going again?
Yeah, Claire's obviously one of our anaesthetists, and they are all doing resident shift night shifts and so forth.
No, I completely understand. I didn't expect a response in a way, but I don't know how to proceed without your input now.
No, that's fine, Lynn. I'll pick that up.
Very much, Carl. Angela, is there anything you would like to add to your report today?
I think just to be aware that some of the areas have been suspended around harm-free care, etc. nationally, but we are still monitoring those, and we took the dashboard to Quality Committee last week and went through some of the areas. We've still got a focus on tissue viability, pressure ulcers, falls, etc., and we're monitoring those as we go along to make sure there's not deterioration in the quality of care during this time.
Thanks very much indeed, Angela. Callum, anything you'd like to add to the report, please?
No, just to point out the mortality section, we are continuing to do, you'll see that we've done 90% of stage 1 death reviews, and I've spoken to Carrie Kelly because clearly it's critical that we preserve as much of our mortality work as possible. That should be easier despite COVID now that we've got a learning from deaths nurse in place. So just to give assurance that we are progressing with that. I think the number of structured judgment reviews will be done on an economical basis, and therefore focusing on the really important ones, which we are continuing to do. But I have been also having conversations with Suzanne Stubbs about making sure that we start to plan in timetabled structured judgment reviews, particularly within medicine, on a weekly basis, so that as soon as we're in a position that we can start enacting a lot of that we're good to go.
Thanks very much indeed, Callum. Richard, please.
Thank you. Just a comment and a sort of question for Callum. Clearly, we've had a lot more deaths recently due to COVID-19, as has the country, and those will at some point flow into our mortality statistics, which will be hard then to compare to normal. I wonder if Callum could just say a few words about how that's likely to play out.
Yeah, no, absolutely. So, just to remind colleagues, when Louise Tuckett and colleagues did some analysis of how we're capturing data, it transpired that about a third of a non-elective activity was not being counted as non-elective activity, but being counted as observations, and therefore almost certainly negatively skewing our HSMR, because those patients were not being captured within our HSMR data when they should be. We therefore changed that from the 1st of April, and therefore we would expect in a couple of months' time a notable improvement in our HSMR. However, clearly that is now being complicated by COVID, and as Richard said, nationally and indeed locally and regionally, we have seen a significant increase in the number of deaths. Almost certainly a significant number of that is due to COVID, but almost certainly equally there is a large number of patients who have died who otherwise wouldn't have done because there's delayed presentations, people not coming to hospital, etc., etc. In terms of what we do about it, we are, as I said, continuing to review the majority of all deaths at a stage 1. We have preserved the harm-free meeting and the serious incident panel, and clearly continue to monitor Datex for any instance to do with quality of care and so forth, and that includes mortality. Equally, we as an organisation would expect a proportionately increased number of deaths in line with other regional partners. So I think the national rebasing, whilst we've seen an increased number of deaths locally, that is true nationally. And so there should be a stepwise increase nationally, and therefore that would offset our own increase because clearly HSMR is taken from a national baseline. But that will...
Thanks very much indeed, Callum. There's no more indications for any further comments, so let's move on to the operational report, please, on page 77. This is our Chief Operating Officer's report, George Briggs. Any questions or comments of George, please, on this report? No specific questions there, George. Is there anything you would particularly like to highlight for the board?
Yeah, I think just to reinforce that message about the whole landscape has changed, but within that landscape, there are some real positives for us. Our complex patients, delayed transfers of care, has been between 0 and 2 patients for the past month and a half, and we've seen a major sort of reduction in medically fit patients across the organisation. Our A&E standards that we're working to, the new sort of ones we're trialling, although the trial is on hold, I'm expecting that at some point in the next few months to get some feedback from the national team about what we do next and how we do that and what they're expecting of us. But the standards are the best we've ever seen. There is clearly the strange bit about the fact that we've got 100 less patients going through our A&E department, but the team are dealing with really complex patients, split across a number of areas. We've had to increase the number of resus beds, and we've put another resus area within there. So it's not as if they're not doing anything, but I think they're doing it a lot better than they did previously.
Thank you for that, George. We've had mentioned on a number of papers already the improved or practical place relationships in Rotherham and the good working that's taking place. How has that manifested itself then, George, in terms of what do you sense is being different? I know the numbers coming through are obviously reduced, but also at the other end, as our patients are moving out of the hospital, what's actually changing in that regard?
We've seen a major reduction in barriers. So barriers previously about conversations about who funded what, about the appropriateness of patients to go into care homes, the workload of the social workers, all of that, as we flagged it up, has been sorted. The RMBC and the team there have been really helpful. They've put additional social workers in, they've created additional community beds, and their ethos has been get the patient out of the hospital and deal with the problems in the community rather than in the hospital. We've just seen a complete change in the way RMBC are working with us.
Oh, that's good to hear then. So, I mean, it'd be good also if we could maintain that kind of mantra, wouldn't it, going forward? Because that's been our major challenge, really, of getting people who are fit to leave hospital, getting them out of hospital. So that would be good if that's one of the changes we could actually sustain going forward.
Yeah, it's essential. We've got to keep that going.
Okay. Thanks very much indeed, George. Let's now move on to the workforce report, please, page 92. Again, any questions or comments of Steve on that? Mark and then Lynn, please. Mark first.
Well, it was interesting to see, Steve, some of the learning and development stuff that you seem to have adapted scenario, some sort of online stuff, I guess, stuff accessible in the hub. You've talked about corporate induction being accessible in the hub. How have things like that worked? And is there anything that you can bottle up and use again in the future once this COVID pandemic sort of fades away a bit? Are there new ways of working that could be used in the future?
Thank you. Lynn, please.
On page 95, or it might be 94 actually, the bringing back staff scheme, Steve, you could break that number down a little bit into the type of worker that has returned.
Thank you. Any further comments or questions of Steve? Heather, please.
It's a question around the third year student nurses and any medical students who have had their training accelerated and come on board as Band 4 nurses, etc. How are we ensuring that they're getting the adequate support to take them through what must be a very trying time for them?
Thank you. Are you going to pick that one up, Callum?
Okay. Yeah, I'll pick up on the medical student assistants and also the final year medical students who had accelerated graduation that are starting shortly. So the medical student assistants, they have a full 2-day induction process taking into account social distancing, of course. They've all been allocated to different areas with supervisors allocated to each of them. Stuart Richards, who's one of our ENT surgeons and postgraduate training director, is leading on that. I have written to all the medical students who are doing volunteering with an organisation to offer personal support and also to support them by their ability to raise any concerns or any problems that they may need, or any areas where they feel that they need a bit more support. We've had lots and lots of positive feedback within the areas. Actually, they haven't been needed quite as much as we predicted, but clearly it was much better to get as much help in as we could, even if we didn't need to use it as much as we might have otherwise have done, and very few issues, all of which have been picked up. But I think they are being well supported.
Thanks very much, Callum. Angela?
Sorry, I couldn't find my unmute button. The student nurses that have come on the final 6 months, we're calling them aspirant nurses, and they've been welcomed into the organisation. They've chosen the areas that they want to actually work in, having worked in the trust previously for most of them. We've allocated them to a buddy mentor within each of the areas. We undertook a 3-day induction programme and did a welcome meeting with the senior nurses, and I filmed a little welcome to them as well to be played to them before they join the organisation while they're in university. We've got days that have been allocated for them to have more support and education out of the work environment to enable them to get the skills very, very quickly that they'll need. And we've started the preceptorship programme for them early so that they can actually get into their stride and get supported in the organisation. At the moment, the feedback's been really positive from them. They're really loving it. We've already got 50% of them got permanent jobs with us, and now we're working on supporting the others so that we'll get those as permanent at the end of it as well.
Good. Thank you very much for that feedback. Excellent. Steve, coming back to yourself, if you could respond to Mark's question and Lynn's, please.
Yeah, so hopefully the student nurses and doctors has been covered by Callum and Angela. Mark's question is about new ways of working and how we've delivered some of the education and training, learning and development during the COVID crisis. I guess similar to lots of other things in terms of operational performance, etc. If you'd have asked me before COVID, could we do these things? It would have been, no, that's really too difficult. But never wasting a good crisis, we've actually adapted, as you highlighted, Mark. I think there are some key lessons that we can learn taking forward in terms of how we deliver education, learning and development going forward, because we've seen a sea change in our ability to adapt, which I wouldn't perhaps have predicted before COVID-19. So yes, I think the education, learning and development team have done a really good job, and we will bottle those lessons and take those forward as we get back to normal. Lynn, I think your question is around bringing back staff and having a breakdown of those staff. I've got the exact figures, which I will circulate after, but predominantly it's nurses and allied health professionals who are wanting to come back. It's been a bit of a clunky system because the system has been operated nationally. So anyone expressing wanting to return to come back to the NHS has had to be managed through Yorkshire and Humber. I think lesson learned from there, it probably would have been better managed at a local level. So I will circulate the exact figures, but we've had a good response and actually a proportionately better response than some other trusts in the area.
Thank you very much for that feedback, colleagues. All done on that. Thank you for your report, Steve. Let's now move on to the finance report, page 96. And again, any comments, questions anybody would like to make on this particular report, please? Before we ask Michael to pick up any specifics. Mark, did you want to ask a question? Your mute buttons.
My mute is off. It is off, isn't it? Yes. I suppose, we've all asked the same question. I was just wondering whether, what the timescale is, I suppose, for that sort of post-mortem, trying to work through what happens. I know it's very difficult to predict the future at the moment, but I was just wondering what, I suppose Richard in particular felt would be the right, and Michael, felt would be the right timescale for trying to think through the lessons learned.
Okay, well, let's pick that up specifically before I ask Heather and Mike to comment. Richard, are you wanting to respond to that one, please?
Yeah, and I think we've talked before that we would need to get a full review of how we ended up where we did and the processes that led to that. So I think we need to get on with that as soon as possible, because what we need to do, in my view, is to identify any lessons and put them right before we exit this temporary COVID finance period, which is in some senses protecting us from any ongoing legacy issues from last year. So there are some complicating factors which I don't really want to go into in public at the moment around that, but I think we should try and get an independent review set up in the next month if we can, in my view.
Okay. Thank you, Mark.
I think that's right, but I was just wondering whether we should crystallise that, therefore, in some sort of work plan for the board, just to agree, how and when that review will be kicked off and started, and then when we expect to see some answers coming out of it, because otherwise it will just drift. Well, I know you won't allow it to drift on, Richard, but it'd be good if we can just have some clear plan on when that's going to report back to us.
Yeah, in terms of, I guess that depends how comprehensive, and it depends on the terms of reference we put together for the plan. So I would want us to get to a position where certainly within the next, within the first 4 months of the year, we've got that done and completed. But these aren't quick and easy things to do, as you know, and I've been through them in 2 previous organisations, and they to do them right, they tend to be reasonably comprehensive and may require us to go through a tendering process to appoint people to do it for us. Now you can do that fairly quickly, but the first step of that is for us to work up the terms of reference, and Michael and I have started thinking about that based on some other reviews that we've been involved with to get, use that as a sort of starting point to then decide what we need to make ours look like. But what we thought we would do is draft something up and obviously get the views of all the relevant colleagues on that, many of whom are on this Zoom meeting, so that we can get an agreed set there. It's also likely, of course, our external regulators want to have the opportunity to comment on those.
That's very helpful, Richard. I think in terms of timescale, we should be able to bring something back, I would have thought, to our next board meeting that actually does in fact explain what the intentions are, isn't it? And we'll think through what the sign-off process is for any terms of reference and tendering in the intervening period. So I think your point, Mark, in terms of actually having a milestone around that seems to be a reasonable one prior to the next board meeting. So thank you for that. Heather, you'd indicated you got some comments, please.
It's just it's one for the future as we come out of the COVID financial regime and move back to whatever the new normal is going to be. I think one of the areas that's not worked well this year and we have not dealt with well is the quick schemes, which have not delivered. And we've had quite a lot of extra activity in certain areas because the quick schemes haven't worked and the funding around that. So it's making sure that we address the correct mechanisms for that going forward.
Thank you, Heather. Mike?
Yes, Chairman. There's a throwaway line in paragraph 211, which says that increasing costs for bank staff since the transfer to NHS professionals towards the end of the last calendar year. Well, there's a couple of things about that. The first one was that the transfer to NHS professionals was supposed to save us a six-figure sum in savings. So to actually have more expense through it is very, very worrying. And the other one is that at least the initial feedback from staff was that actually using the NHS professional system was not easy. And if we're not able to do something about this, or if we haven't done something about it, we could have a double whammy where if access is found to be better, but we're still paying more, we could actually see this problem get worse rather than better.
Okay, thank you, Michael. Richard, I think you wanted to comment before we ask Michael.
Yeah, I just want to ask a question about cash. There's a short bit at the end under 5 about cash, saying what the year-end balance was. But obviously I'm new to the trust, but and one thing I wanted to have a look at was what was our opening cash position, and I think we borrowed significantly through the year against a plan that was supposed to be a balanced plan, which I think might be something we need to have a think about as well, because of course there's the view that historic debts are going to be converted to PDC in September this year, which is probably a good thing. I guess it depends what the charge for that is and how that our income is adjusted for that. But Michael, could you say anything more about the cash position through the year and the borrowing?
Yes, certainly. My understanding is that we did have borrowings during the year and we did apply for advanced financial recovery fund monies. The figure I've seen is circa 12 million, but I need to understand and unpick it in a little more detail with an expectation that we will be paying some back at some point. But I think that expectation will now disappear in terms of repaying those monies. But certainly we will be looking, and Heather mentioned around information around cash going to F&P this particular time, and it was lacking in detail. I've set up a cash committee which will meet on a weekly basis, and as part of that I'll start to unpick the reasons for the loans. Because if we were borrowing in greater values in our deficit position, I guess that would give us an indication that we've got some other issues. I suspect the level of debtor accruals will have had an impact on any requirements to borrow. But that's as much as I know at this point in time. I don't know if Heather can come in and add anything, please.
I could. There are a couple of other issues that should be looked at. One is which has influenced the cash drawdowns is historically there has been a very long time lag in the authorisation of invoices. So a lot of invoices were trapped in I can't remember whether it's status A or status B, and a lot of work was done during the year to accelerate the approval process. So more historic catch-up was paid off during the year. But there is an issue, there is still an issue in there around the income accruals and the prepayment, which has manifested itself in this year and is having to use in current financial year some of the public dividend capital which was allocated for capital projects that's been used to pay off the revenue credit. So that's a problem that's going to hit us in another couple of months, which we discussed at FPC, and Michael is doing some work on that.
Okay, thank you for that, Heather. Michael, do you think you could now address the other remaining questions, please, that were raised?
Yes. So in terms of NHS professionals, we'll start with that one first. We are looking at that in detail, and I'm working closely with Angela and colleagues. We've got the bank and agency group set up on a weekly basis. We've turned on the golden keys that has resulted in the removal of one agency, and there's a potential for turning on a further tier of reduction that will improve that position. We've got an emerging picture of the bank and agency costs for April, and it appears that they're £250,000 less than they were for March. Some of that will be a lack of ability to fill, but some of it will be less requests. Now, a lot of that will be associated with COVID and the closure of the wards, but we'll start to look, and Angela's producing more detailed information, more granular information that will help inform our group, so we can have a look at the decisions that are being made to bring individuals in. I don't know if Angela would like to add anything at that point. I'll just pause. Thank you.
Yeah, I think obviously we're looking from a day-to-day basis what is actually being used from the bank and agency position, and we've been working with Power BI to look at a dashboard to identify exactly what staff are across the organisation at any point, and what requests for an HSP and what utilisation we've got. So we'll be able to have an app that we can look at on a daily basis, and that can then be linked to finance, so we know exactly on a daily basis how much we're spending on bank and agency across the organisation.
Thank you, Angela. Steve, please.
Just to add to what Michael had said around NHSP, and I think trying to pick up Mike's point, which I think, Mike, you were alluding to the operability of NHSP and some of the teething problems around it. One of the issues I think there relates to how the system for NHSP talks to e-roster, and I think nurses finding that difficult in terms of visibility. So we have authorised a fix which makes NHSP talk to e-roster, so that should address that particular issue as we go forward. Just wanted to add that to what Michael had said.
Okay, thank you, Steve. Michael? Go on, Michael. Unmute, please.
Yes, thank you.
Mike Smith.
Thanks very much. The issue as I read it, though, is that there's a system issue within NHSP that seems to have ramped up prices. And I'm asking sort of not for control of expenditure on a day-to-day basis and on a headcount basis, but what is it within NHSP that's made these increases go up per unit?
Okay, sorry, can I Michael, Heather, is yours on this same issue?
It is on that same issue. This is one of the post-business case authorisations that are coming back to FPC for an implementation review, and did it deliver on what we said? And I think that is scheduled to come back to FPC next month.
Okay, thank you for that, Heather. Michael, anything else you'd like to add, please? Michael Wright.
Thank you, Martin. So we'll certainly have a look at, do a post-mortem of what's actually happened with the increase in rates. I suspect some of it will be down to the additional agency usage. Some of it will be down maybe to a reduction in bank because the rates are less favourable than they may have been previously when we had our own internal bank. So there's a few variables that we need to focus on. I was just going to move on to the next area, if that's okay, unless there's anything else on bank and agency.
Please. No, keep moving now, thank you.
Thank you. So I think I've answered the questions on cash. We've touched on bank and agency. The other thing I just wanted to bring the board's attention to, if that's okay, was the deficit that we're posting. Previously at board, we discussed a deficit of 3.9 million. And as a result of posting a 3.9 million deficit and the ICS system being in aggregate balance, you would, as a trust, therefore qualify for additional financial recovery fund monies in the form of deficit reduction monies, taking us back to a break even. More recently, it has emerged that the ICS position is more favourable than aggregate balance. As a result, we have the opportunity to post a 4.9 million deficit. That 4.9 million deficit would then be cleared back to a break-even or very slightly favourable as a result of additional financial recovery fund monies being available. So that is a £1 million improvement. We took the decision to accept that and post a deficit of 4.9 million. And in doing so, we would revisit the mitigations that we had in place. And our approach has been to remove one of those significant mitigations where our confidence levels were maybe less high than in other areas. So I think that is a sensible approach, and it gives us a position where we'll have the deficit cleared back to zero, and we will still keep our PSF and FRF funds that we would have earned in Q4 of 5.1 million. And at that point, I'll just take any questions on that. Please, Martin.
I think I'd just ask colleagues just to indicate is we all would endorse that position, having of actually reducing our risk into 2020-21 as a result. So that was a good opportunity for us to improve our position going forward. So thank you for the negotiations there. Anything else on finance before I move on? Okay, thank you for your report, Michael. Let's now move on to the NHS Resolutions Maternity Incentive Scheme, page 105. Any questions of Angela, please, on this report? There's no immediate questions, Angela. Is there anything you would like to add to your report, please, before?
No, I don't think so.
Okay, so all happy to note that report on this occasion? Thank you, Angela. The next item on our agenda is the Complaints Annual Report for 2019-20, which is actually for our approval. You've had this in advance. Any questions or comments on that particular report, please? Joe, and then Mark, and then Heather. Joe, Mark, Heather. Thank you.
Thank you, Martin. I've mentioned this to Angela, but this time last year when we had this report, we said that we would append to it the quarterly report from the non-executives from their reviews of complaints, and that hasn't been done. I understand at the current time why that might have been overlooked, but I wonder if we can make the board planner clear for next year that should be part of this report to us.
Okay, thank you, Joe. I mean, we agreed that last time, so let's reaffirm that and have that entered onto the board planner then. Thank you. So hopefully Anna and Dawn will be able to include that in the minutes. Thank you. And then we've got Mark, please.
I think it's a really good report. I just had a question about section 14, which is page 121 onwards. I think there's also some good examples there of where the trust has learned from a set of complaints and often some other feedback routes as well. But I guess the challenge is always for us, isn't it, to make sure that those learnings are then embedded and they then don't reoccur as future complaints. And I guess some of them often do. The second one on page 122 is often a theme, isn't it? Poor communication between team members and patients. And I don't know what the answer is. I was just wondering whether Angela's got any ideas, and I suppose Steve and Ed have got some ideas about how to embed some of these messages, particularly about things like communications, to ensure that it's at the forefront of colleagues' minds at all times, so it doesn't then reoccur as a deficit in terms of the quality of care. I don't just want to pick up on communication. It's a more general point about how we make sure that those learnings are embedded and refreshed on a constant basis.
Just hold that, please. Heather, you've got a question, I think.
It was what Mark's just said, but also it was a comment about the complaints being closed in the timescale, which is just really disappointing that we've had a fall off again. It's where we've been in the past, and it's how do we embed things so that once we sort something out, it continues to stay working.
Okay, thank you. Richard?
Yeah, I just wanted to pick up about concerns, because we have a lot more concerns than we have complaints, which is normal and right. But how do we make sure we capture the learning from concerns that doesn't really feature in these reports? Because it might well be there's a very high volume of minor issues that we need to be aware of that might not precipitate a complaint.
Okay, thank you. So those are the questions. Sorry, Mike, go on, Mike Smith.
Yeah, it sort of leads on from what Richard was saying. I was the non-exec who did the last quarter's review of complaints. So there's a random sample that you just picked 6 numbers. Out of 6 that I looked at least 2 of them were about communication. And it was fairly obvious from looking through the file that the communication wasn't at the fault of the team member. It was actually a lack of understanding without reason in those 2 cases by patients themselves. And I think what Richard is saying is that there are concerns being raised, often minor in nature, but there are other issues, particularly in the medical field, of misinterpretation. It would be very useful, I think, perhaps, to look at a communication one and see how many of those were upheld, because the nature of the beast, whether it's retail or in hospital, is that people say, I was never told that. So I think it's worth looking at these concerns in more detail.
Okay, thank you. Well, obviously this report has highlighted a number of continuing concerns and issues to address going forward. The issue today for us is actually approving last year's annual report. So that's really what we want to get a decision on. But I'm assuming, Angela, you will have actually picked up quite a lot of the reactions to the report, and you'll obviously take those into account going forward. Is there anything particular and specific you'd like to add at this stage?
I think obviously we're working on the complaints processes within the organisation and how we are learning from complaints, but also from concerns. My team has been increased to support patient experience. So I've now got an assistant chief nurse for patient experience who's been on secondment with us, but the advert will be going out next week for the permanent position. And that role will be looking at triangulating the information and taking that back to the divisions and working with the divisions to make sure that learning is actually embedded. I think from a timescale point of view, it is disappointing that we haven't met the timescales that we've set ourselves, but we've seen an increase over the last few months in that with the work that the team have been doing and taking forward. We have obviously got a complaints process in place at the moment, but it's sort of been modified slightly with COVID. When we go into the post-COVID era, we'll be looking at making sure we've got appropriate mechanisms and support in place. The division that's been struggling, we've made sure that we've got some extra support in there, and there is going to be a substantive member of staff appointed to that team. So we're hoping those timescales will improve.
Okay, thank you. So coming out of that is actually focusing on ensuring that we embed the learnings from our complaints, and indeed raise is important. And obviously going forward as well is a day and the target that we have. So thank you for your report. And with your, sorry, Joe.
Just to go to, excuse me, the last item you mentioned on embedding, was the internal audit report, which did make specific recommendations on that. And Angela's included reference to that on page 123. So there are some specifics which are being put in place to help to address that. I'm not saying there's nothing else to be done, but there are those specifics.
Yes, and the report actually talked about the things that we are going to develop and improve going forward into 2020-21. So thank you for that. So on that basis, all agree and approve the report? Agreed? Thank you. Let's now go to the governance report, please, on page 125, which is Anna Milanek's report, our company secretary. Any questions or comments on this report, please? I've got Nicola, please. Nicola.
Thank you, Martin. On section 4, with reference to the ability of staff to speak up, I just wondered if there'd been any key on this point during COVID.
Thank you. Any further questions or comments on this report? If not, Anna, are you able to respond to that question or open it wider?
It's probably a question for Angela, to be honest, I think, because she would be more closer to anything that has come out of the COVID.
Good. Thank you. Angela?
We've encouraged people to go to the Freedom to Speak Up Guardian if they've got any issues around the situation around COVID. We've directly responded to some staff around issues, identifying, as we put in the quality reports, etc., around our management of PPE and the fact that we haven't had any reductions in PPE that have meant staff haven't had the appropriate equipment, etc. But we're certainly making sure we're listening to people's feedback and giving that appropriate advice and support across the organisation. We're using the communication channels. Our comms team are really good at providing information, and if we get feedback, we make sure we reinforce any messages across the organisation so that staff are fully aware of what we're doing and how they can get support.
Thanks very much indeed for that, Angela. Anything else you'd like to add to your report, Anna?
If I could just add one thing, we do usually have the quality account that comes up to the board in May and June. We had guidance on Friday, actually, that the quality accounts don't have to be submitted now until December 2020. So it's just to highlight that obviously our planners, etc., will be adjusted to account for that.
Thanks very much indeed, Angela. Sorry, Anna. So we actually note that report. We now have the People Committee Terms of Reference, which have been to the Assurance Committee during the cycle, and they're presented to us for approval. Callum?
Just two observations, really. One was just a typo, and the second one was just the practicality. It says in attendees, the Chief Nurse is expected to attend all meetings. I'm not sure how practical that is. And just the second thing is just on page 131, under meeting administration, the third bottom paragraph, where it says responsible to send them to the committee chair just the word for needs removed.
Okay, can I come back to you, Richard, please, on the attendance at the meetings, if you wouldn't mind, because we talked through this about what the membership of the committees are.
Yeah, no, I think my view is that the attendees from the executive team are expected to be there. And that's part of just trying to increase the executive contribution, but increase the breadth of portfolio in the room. So, of course, it's possible to give apologies, but obviously we'd rather that was very rare for an assurance committee.
Okay, thank you. Can we pick up Callum's points that he's made with regard to the grammatic issues and the terminology? Are they accepted, those changes? Okay, Callum, did you want to come back?
Sorry, Martin, there's a couple more grammatical issues.
Yeah, sorry, I'll come back to you, Joe, in a minute.
It's just to say that there's a couple more grammatical issues, which we can wrap up together if that's okay with everyone.
Yeah, thank you. Callum?
Sorry, Chair. It was just really, I entirely agree with Richard. It was being explicit that effectively the Chief Nurse needs to attend all 12 meetings in the month. It was purely just the way it's worded.
Okay. Well, let's just ensure that is the same for everybody, because clearly the membership is the membership, and we expect people to attend. Although on some acceptable it will be sent. But I think the real norm is that we'd like executive colleagues to be there. Joe, you were saying something. You said there's some additional grammatical things that we'll wrap up together.
Well, they can all be wrapped up together, Martin. Yeah, on page 131, the bullet point in red's got a capital letter, for example, and we've got a chair discretion, which doesn't work, the English. So they can all be tidied up. They're not matters of substance.
No, okay, but it doesn't change the actual approval of the terms of reference. Okay, I've got Nicola who would like to speak, and then roommate. Nicola?
Thanks, Martin. Just a couple of points which I talked to Lynn and Steve about. One was, I think, just to make explicit that the People Committee will focus on areas such as leadership development, talent development and succession planning, in addition to those referenced on page 131. And then the second point was at the bottom of 131, it refers to a table below around the matters for the committee, which I just wanted clarification on.
Thank you, Rumit. Rumit, please.
Sorry, I didn't have anything to say. Sorry.
Sorry, I thought you indicated a little earlier. Steve, anything you want to add, please?
No, I think Nicola and I had an exchange around that, so fully endorse the leadership point that was made. I think we do need to, whether this is the work planner or the terms of reference, we do need to be explicit about what the People Committee considers and has within its remit. And this kind of goes back to my earlier point about the demarcation issue. So I think if colleagues are happy with the grammatical issues and the addition of leadership, if we could finalise the terms of reference, we could probably pick up at the next People Committee what the remit is, what the work plan is, and what we will cover going forward.
Okay, thank you. On that basis, I'm sure, Richard, as we said earlier, we'll have a look at the clarification between the role of the Finance Committee and the role of the Workforce Committee. But notwithstanding that, are we all agreed we can approve the Committee terms of reference subject to those comments that's been made? All agreed? Thank you. We have no any other business formally, but we do have our clinical colleagues here from the division that they would like to raise, please, bring to the attention of the board at this stage. If I could look to you, Jeff, first.
Nothing from me, Chair.
Okay, thank you. Jez?
No, that's fine. I think that's fine. I think most of the points I would raise have already been raised, so that's good.
Thank you very much indeed. Jill?
No, nothing from me.
Thank you, Jill. Andy?
No, thank you, Chair.
Okay, thank you very much. We've come to the end of the meeting, and clearly we've had a couple of our governor colleagues attending the meeting today. So if I could look to yourself, Gavin, and Mike. Gavin, is there anything you would like to raise or ask a question of? Gavin?
No, Martin. Sorry, I pressed stop video instead of unmute. Apologies. No, I'm fine, thank you.
Thank you. Mike?
No points. Thank you very much indeed, sir.
Okay, thank you. On that basis, all the business is done for today. Thank you all very much indeed for attending the meeting and indeed for your contribution. So this meeting is closed now just before 10:45, and the colleagues will reconvene for some confidential items at 11:30. Thank you all for your contributions. Bye for now.